the week 8 quiz review. We're going to jump first to opioids. I'm going to start the top left, and I'm going to work my way around in a circle. I'm also, just a second here, going to pull this out, and what I want to do is I want you to start up here in the left. So this works, opioids work on the opioid receptors. They are analgesics, so they work on pain. They are used with severe pain, so like 8 out of 10 pain. So if a child is on this, the parent should be in control, not the child. That means anybody who's a minor. When people are on this, when they're coming into the ER or they're coming into a clinic or they're going to be discharged from the hospital, they need to know not to drive while on this medication. So this is a CNS depressant. Any opioid is a CNS depressant. It can cause confusion, decreased LOC. Do not operate heavy machinery. You need to teach that to patients. Physical dependence can happen with these. And so when it's stopped, if somebody's been on it for a long time, you can see some vital signs changes, and people can get anxious, and they can also have a lot of pain associated with the removal of the pain medication. Addiction is rare when they're used appropriately, but addiction does tend to happen, especially when people are using them inappropriately, illicitly, but it can happen. They should seek medical attention if they feel it is starting to happen. Okay, so tolerance is a little bit different than those things. Tolerance can also occur in a lot of people who have been on things like if they have cancer and they've been on things like oxycodone, OxyContin. Oxycodone and OxyContin are often used for cancer pain. And what will happen is people, after they've been on it a while, tolerance will occur, and the same amount of the med that they were getting no longer exerts that analgesic effect. So it will need to be increased to get the same effect. Please note, all opioids can cause urinary retention and constipation. They can cause respiratory depression, which is by far the most important thing to be watching for. So if respers are 10 or less, oh my goodness, you've got that naloxone ready to give. Okay, people can get morphine, hydromorphone, and fentanyl via PCA pumps. PCA is patient-controlled analgesia. There's an initial bolus and then a basal rate, so a continuous basal rate that can be given through these. The patient bolus is the one where they give themselves the quote-unquote bump with that little button you can see in the top picture. And that little bump, that should always be given by the patient. Okay. Other opioids are morphine, hydromorphone, fentanyl, heroin, oxycodone, OxyContin, hydrocodone. You can see that heroin is not legal. Fentanyl has street value as well when people are not using them appropriately. That's when addiction levels are high and risk is high. So let's talk about first-generation antihistamines. The most famous one is diphenhydramine. You may know it as Benadryl. First-generation antihistamines block H1 receptors to prevent the action of histamine at the sites. Hence, they are histamine blockers, antihistamine. They are used for allergy, nausea in children. They're used for sleep. They're used as a pain adjunct. There are all sorts of different uses for them. If you look over on the top right-hand side here, it says other first-generation antihistamines include dimenhydrinate, which you can get actually at gas stations for motion sickness. You would never take that if you were the driver, but passengers can take that for motion sickness. Hydroxyzine is used for things like anxiety, itching, and a myriad of other things. You want to let people know to avoid alcohol and don't drive or operate heavy machinery. While you're taking first-generation antihistamines, they can cause drowsiness. And it's this drowsiness and the fact that a lot of these first-generation antihistamines don't have a long duration of therapeutic effect. So we're going to move on after this to some medications that were made to try to solve those problems. Because of the anticholinergic effects, people can get a dry mouth, so you can tell people to chew gum or suck on hard candy if they have those anticholinergic effects. Second-generation antihistamines include things like desloratadine, fexofenadine, cetrazine, loratadine. These are also histamine blockers. They also block H1 receptors to prevent the action at the histamine sites. They are also used for allergies, but they cause less drowsiness than the first-generation antihistamines. And of note, you should know that these also tend to last a little bit longer. There are some of them like fexofenadine that have 24-hour versions, right? It still has the anticholinergic effects. People still get dry mouth. So chew on gum or suck on hard candy. These are given orally. We're going to move on to first-generation NSAIDs. They are COX-1 and COX-2 inhibitors. They're given for pain, inflammation, and fever. So pain, they are analgesics. They're given for inflammation, so they're anti-inflammatory. And they're given for fever, so they are antipyretic. First-generation NSAID stands for non-steroidal anti-inflammatory drugs. They include things like ibuprofen and naproxen. Also, they include things like ketorolac or Toradol. We talked about that in class. So when we talked about those, and we also talked about down in this lower left-hand corner, there's a little disclaimer here. Some resources will classify aspirin in its own classification. Aspirin is also abbreviated as ASA, which is why I've put it like that and down in that left lower corner. And ASA is aspirin. It's also salicylic acid. And so it sits in its own category sometimes as a salicylate, and some books, some resources will go ahead and classify it as an NSAID. Okay. All of these drugs increase the risk of bleeding. All can cause GI upset, heartburn, nausea, gastric ulcers. They can be hard on the kidneys, especially when overused. Ibuprofen and naproxen specifically they're associated with thromboembolic events like MI, but they aren't as risky as the next one that we're going to talk about. The next one's more risky. Aspirin in particular is known for ototoxicity, so people can get something called tinnitus or a ringing in the ears, especially if it's in high levels in the blood. Reye's syndrome is something we should briefly touch on here. Do not give aspirin in particular to infants, young children who have viruses, because it is known to cause Reye's syndrome in young children and infants that have viruses. With any of these, they increase the risk of bleeding, so stop 1 week before surgery. If somebody's taking them, oftentimes they'll be taking them over the counter, so let them know they need to stop 1 week before surgery. All right, we're going to move on to second-generation NSAIDs. There's still that COX-2 inhibition and that anti-inflammatory property. Really and truly, we don't give these to reduce fever. but we do give them to reduce pain and inflammation. Second generation NSAIDs were designed with the idea that they would cause less gastric mucosal irritation and less likelihood of bleeding. But guess what? There's a huge risk, big risk for MI, myocardial infarction, and stroke, anything that involves a clot. And so these really aren't used a ton anymore. This one's called celecoxib. You might know it as Celebrex. All right. Let's just reiterate, though. It is used in some situations nowadays, though, because it is, there are people who have been on it for a long time. And it is that principle that, I've told you about before, if it ain't broke, don't fix it kind of a thing. And so they've stuck with it. But it's not something that they generally start people on anymore. Okay, so another analgesic is acetaminophen. And acetaminophen is a pain antipyretic, COX-2 inhibitor, but its effects are limited to the CNS. There is no anti-inflammatory property to Tylenol, to acetaminophen. It does provide analgesia and antipyretic properties. So it brings down a fever, brings down pain, but doesn't do anything to the inflammatory process. There is this weird thing where people can have hypertension with daily use. That's controversial as to whether it's from the actual medication or if it's from the actual pain. Okay. So for a normal healthy adult, do not exceed 4 grams per day. For an elderly patient, don't exceed that 3,000 milligrams. With children, Tylenol is weight-based. I want to make another clear assertion here is also if someone is known to have regular alcohol consumption, so if someone is known to have regular alcohol consumption, we should make sure that it's less than or equal to 2 grams. If liver disease, their doctor will probably, their provider will likely say no acetaminophen. Okay, so if someone's known to have regular alcohol consumption less than or equal to 2 grams, if liver disease, their provider will likely say no acetaminophen. As research progresses, you may see the 24-hour recommendations to be 3 grams. These recommendations are subject to change. What I'm going to do is, to avoid confusion, I'm going to just block this out, but I left it here so that you could know that yes, there is this idea out there that that these recommendations are going to change. So acetaminophen can be given orally, rectally, and it's odd, but there are IV versions, and they're often used in OB. In normal doses, this is okay during pregnancy, so it's category B. So during pregnancy is okay. Breastfeeding, we usually change over to ibuprofen. Dangerous overdose can cause hepatic necrosis, hepatic failure, death. So we're going to monitor LFTs, liver function tests like AST, ALT. Mucomist, something called acetylcysteine, you need to remember that, is it's given in an attempt to minimize the liver damage. So early symptoms could be nausea, vomiting, diarrhea, but then later symptoms of liver damage, you're going to see the jaundice, you're going to see the excessive bleeding, especially in the stool. You're going to see a lot of fluid accumulate in the abdomen called ascites, all that kind of stuff. But acetylcysteine is something that we will give during the acute phase if someone has overdosed on acetaminophen. Okay, so let's move on to glucocorticoids. Glucocorticoids are given to reduce inflammation, anti-inflammatory. They're used as an anti-inflammatory. They're used in adrenal insufficiency. They're used for pain, where if we take down the inflammation, it will help resolve that pain. So those with adrenal insufficiency should wear a medic alert bracelet, because then it can be known that they should be given certain medications if they have a crisis, right? So glucocorticoids, there are versions that are PO, IV, inhaled, IM. Specific injections by the provider are sometimes given in joints. The tapering of these medications should always be done with the provider. A person should not be in charge of their own stoppage of a glucocorticoid. Glucocorticoids cause a lot of side effects like weight gain, slow and poor wound healing. They can decrease bone mass, cause osteoporosis, increase the risk of infection. The weirdest thing about this is that there's a lowered immune system, but there will be high levels of white blood cells. And they're just really immature and non-functional white blood cells. It will cause hyperglycemia, so high blood sugar. It can cause peptic ulcer disease. It can cause muscle atrophy, and it can cause fluid and electrolyte imbalances. We're going to talk about allopurinol here for a little bit, and then just a little bit on the other uricosurics. Classification of allopurinol. Some books will put it in the xanthan oxidase classification. Some will call them uricosuric, some will call them anti-hyperuricemic. Allopurinol is used to decrease uric acid levels in patients with gout. It inhibits something called xanthine oxidase, preventing a conversion of a couple of chemicals to uric acid. So then you don't have uric acid crystallizing in places where gravity would cause it to do so. Allergic reactions, as with almost all medications, hold and call the provider. Hypersensitivity reactions can cause liver and kidney dysfunction. Other uricosurics that are out there are things like probenecid and colchicine. Those are also used for gout. Please note that colchicine and allopurinol are often given together in the acute phase, and then allopurinol will be continued and colchicine will be discontinued after the acute phase is over. Drug-drug interactions. There are a lot of drug-drug interactions, but the allopurinol and warfarin, you need to know specifically. Allopurinol and warfarin will likely need to be reduced due to the increase in INR. So allopurinol is contraindicated in liver or kidney dysfunction. So think about the labs that need to be done prior to starting allopurinol. Things like LFTs, like AST, ALT, creatinine, BUN. Creatinine and BUN are attached to that kidney function, right? Other adverse effects with allopurinol can include cataracts with long-term therapy. Apparently it's listed twice here. Nausea, vomiting, diarrhea, vertigo, headache, agranulocytosis, bone marrow suppression, aplastic anemia, and then again, we've put cataracts here with long-term therapy. So let me get rid of that extra one there. All right, guys, best wishes, and I will see you on Monday.